with yesterday, the answer to those questions. So I'm going to read the questions to you guys, and I'll give you the answers from yesterday afternoon's questions. So question number 5 was neuromuscular blocking actions act on which receptor for their primary actions? And so you had a choice of muscarinic, nicotinic M, or nicotinic G. And the correct answer for that would be B, which is nicotinic M. The neuromuscular blocking drugs are basically blocking that nicotinic muscular receptor. So the correct answer was B. Question number 6, blockade of which receptor would increase sympathetic nervous system activity? So you had a choice of nicotinic M, nicotinic G, and muscarinic. So let's just go through this. So the nicotinic M is affecting the muscle, skeletal muscle, so it wouldn't be affected. It would not affect the sympathetic nervous system. Nicotinic G is the ganglia, and if you think back to the exercise we did yesterday when we gave you the scenario of an IV injection of acetylcholine, we got an increase in heart rate and an increase in blood pressure, and that was due to actually this question was worded incorrectly. That should have been so if you blocked the nicotinic, that should have been stimulation, so it's a bad question. So stimulation of which receptor would increase sympathetic nervous system activity? That would be the nicotinic G. So that's a bad question. That would be thrown out. So just make a note of that. So blockade of the nicotinic M receptor would not have an effect. Well, let's put it this way. Let me explain. This question could be correct, but the way I worded it makes it very poorly. If we block the muscarinic receptor, that would take away the effects of the parasympathetic system, which would allow the sympathetic activity to increase. So it's sort of a tricky question. The reality of it is, if we blocked the nicotinic M receptor is just out of the picture. If we block the nicotinic G receptor, that would block sympathetic activity because it blocked the ganglia in the sympathetic nervous system. It would also block the ganglia in the acetylcholine. So that would remove both sympathetic and parasympathetic. But if you block the muscarinic, then it would leave the sympathetic unopposed. So the way that it's phrased, the correct answer would be actually C and not the answer B, which I gave you guys. But it's not the best worded question, so I would throw that one out. Question number 7, sympathomimetic agents would blank adrenergic receptors. So sympathomimetic stands for would mimic the activation of the sympathetic nervous system. So a sympathomimetic agent would be one that would stimulate the adrenergic receptors. And then the last question you guys had was, which of the following has minimal action on beta-2 receptors? That was one of the things we covered at the end of the class yesterday, is norepinephrine has the least activity. Isoproterenol has beta-1 and beta-2 actions. Epinephrine has beta-1, beta-2, alpha-1, alpha-2. And norepinephrine has alpha-1, alpha-2, and beta-1 with very little beta-2 activity. So any questions about that one? So again, I apologize for the second question, number 6, which, although there is a correct answer, I gave you guys the wrong answer as far as the key, but it would be it was a tricky question, so I would throw that one out. They're going to post the answers a little bit later, and Marissa, if you would just make a note to eliminate when you post the answers, make some note that question number 6 should be just mark it out, just disregard, bad question or something like that. And you can post those. Actually, you can post the answers of yesterday's and today's first thing in the morning. Will be fine. Okay. All right. Any other questions? All right. So let's. Sorry about that. We will start talking about the antihistamines. We're going to look at antihistamines are going to be important. You're going to have a large number of patients that you deal with that's going to be on antihistamines. Some of these may have significant drug interactions. The other thing that antihistamines are going to be important is because some of the drugs that you actually may prescribe have some antihistaminergic properties. So some of the antidepressants and some of the antipsychotic drugs may have some antihistaminergic effects. And so you need to be aware of what these will do. All right, so let's start with the reason we have antihistamines. Why do we need them? And that falls into the category of basically is because histamine is present in our bodies, and histamine basically is going to have a potential effect on us in numerous ways. Some people actually say that histamine may actually serve as a neurotransmitter in certain systems. I did some of my dissertation research dealing with central histaminergic systems and how it relates to the cardiovascular system. But what we do know is that histamine is very, very widely present. And antihistamines have been used as sedatives. In fact, we see them used a lot of times. Pediatricians have prescribed Benadryl. So it is a pretty common practice. Some people frown upon it. We'll touch on that a little bit. But the drugs can potentially produce sedation. So we have to be aware of that, okay? Now, let's look at where histamine is located. It's pretty widely distributed throughout the body. We know it's involved in several things. We know that it's involved in gastric secretion. One of the things that we will use some of the antihistamines for is to basically by blocking histamine actions that will decrease gastric secretion. And by doing that, that's helpful sometimes with indigestion and helpful. It's one of the treatments that they may use for with regard to peptic ulcer is to decrease gastric secretion using antihistamines. Those are going to act on the histamine 2 receptor, whereas some of the other ones are going to be predominantly on the histamine 1 receptor. Histamine is a big mediator in inflammation. Whenever that you have if you take something, get a splinter in your finger or something like that, what can happen is that can trigger inflammatory response. Histamine comes in, and histamine is responsible for a lot of the signs we see of inflammation, the redness and so forth. Some of the pulmonary diseases, asthma, is considered to be somewhat of an inflammatory disease. And so from that perspective, it is it's a big issue there. So, get back to the question Joy asked, and then Janelle, you weighed in on it too, is that some of the sedative effects of the antihistaminergic properties of some of the drugs are actually due to this antihistamine effects. And over-the-counter drugs that are used for sleep aids that are not prescription, but OTC drugs, basically they usually involve either diphenhydramine or doxycycline. We'll talk about those in just a little bit. So they have been used as sedative effects. Histamine is involved in anaphylaxis and allergic reactions. A lot of the effects, there's a lot of pollen out, and one of the reasons people are congested and sneezing and so forth involves histamine. And then also, as I've said, there's some of the adverse effects that have been identified actually may be due to the antihistaminergic properties of some of these drugs, may account for some of the side effects. In particular, we see two main side effects with these antihistaminergic actions. The biggest one is sedation. So that's always one of the issues that comes into play. We also see another thing that antihistamine actions can do is antihistamines can increase weight gain because they can, by blocking the histamine receptor, they will stimulate the appetite. So that's another reason that's occurring there. So what we see is that in most of these reactions, the gastric secretion, inflammation, the anaphylaxis and allergies, those are all probably mediated from histamine that is released from mast cells. Mast cells are the most common place that histamine comes from. They're distributed all through the body. What we find the other histamine is there are some histaminergic neurotransmitter tracks that appear to be there, but actually from most of the people that experience immediate hypersensitivity reactions, which can include some drugs, it's due to release of histamine from specific mast cells, and those mast cells then, when the histamine is released, it causes all of the effects that we normally would see. This release from mast cells, and one of the things that I do want you to be aware of is that the release from these mast cells, if we were to ask you where is the major source of histamine, it's going to be from mast cells. And what happens during a lot of these times, which causes the release of histamine from these cells, can sometimes be physical stimuli. So, for example, the presence of a splinter that can do chemical stimuli that can occur. For example, bee venom. Most animal venoms will cause itching, bug bites, and so forth. And a lot of those is due to the venom basically causing release of histamine. The other thing that can happen is we can have antigen antibody reactions. So in allergic responses, that when you have something that you're allergic to, let's say you're allergic to cats, and when you go into a room and you've got all that cat hair, cat dander, and so forth, what's happening is that your body has developed antibodies. So the cat dander or the cat hair or whatever, that is the antigen which causes your antibodies to be activated. And when they get activated, basically what is going to occur is they stimulate the mast cells to release histamine. And this can be drug induced. So certain drugs that produce or have allergic responses, anything that can produce an allergic reaction or anaphylaxis, that can be a drug that does that. That's going to be mediated by histamine. One of the reasons why we will use, why we tend to see histamine used from a standpoint of, or I should say antihistamines used in treating those allergic reactions, because generally histamine is going to have some involvement there. And again, what happens, as I just said, is during an anaphylactic or an allergic response, there's an interaction with the antigen, and there is immunoglobulin E, which is actually on the surface of the mast cell. So what happens is when the antigen interacts with that immunoglobulin E, that causes the mast cell to basically release histamine. And then that is part of that response that you see. Now, histamine, we don't use histamine as a drug. Okay, histamine is really more of either a transmitter or substance that's mediated by our body. If someone was to ingest histamine, basically nothing would happen, typically. You might have a local reaction up in your mouth or upper part of that, but generally if it gets to the GI, into the GI tract, a lot of bacteria in your GI tract, also the acidic environment, would basically destroy it. But when histamine is released inside your body, at an inflammatory site, one of the things, if you think about what's going to occur with inflammation, one of the things is that let's say that if you get stung by a bee, one thing that's going to happen locally is it's going to get red. And one of the things that's going to happen is it's going to swell. So the reason that occurs is that histamine will cause the blood vessels to dilate, and it also causes the capillaries to become leaky. So what's going to happen is it gets red because it vasodilates, so the blood vessels around where the histamine is causes the vasodilation, creating the redness. And then what happens is that it starts swelling, because what's going to occur is that the fluid leaks out of the capillaries into the surrounding tissue, so therefore you get the swelling. With an anaphylactic reaction, a lot of people have difficulty breathing, and that's because histamine acts on H1 receptors to basically cause bronchoconstriction. What we do see is asthmatics, their airway seems to be hyperreactive or extremely sensitive. So one of the things that we see with histamine is asthmatics tend to be very, very very, very reactive to histamine. The vasodilation, the capillary permeability, the bronchoconstriction, all of those are being mediated by the H1 receptor. As I mentioned earlier today, we do see that there is that histamine can cause increased gastric acid pepsin secretion, so it increases the secretion in your stomach. That is mediated by an H2 receptor. Okay, so what we find is that these effects here, I shouldn't say the effects. So basically, the vasodilation, the bronchoconstriction, these are mediated by H1. The gastric secretion is H2. And the immune and inflammatory responses relates back up to the vasodilation and the bronchoconstriction and so forth. Okay. Now, there is a whole bunch of antihistamines. We have, and we're going to talk about first of all the ones that have H1 antagonism. Okay. So there is a number of these drugs that are out there. So I've chosen a few of these for you to be aware of. Probably the one that is most well known is diphenhydramine. This is typically sold as Benadryl, but it's diphenhydramine. Misspelled it. It should be HYD. Take that R out, so it should be diphenhydramine. That is the classical H1. There's another one that we see a lot, which is chlorpheniramine. And what you typically see is the chlorpheniramine is relayed or is referred to as being the non-sedating one. So if you were to take something like NyQuil typically has Benadryl in it, whereas chlorpheniramine, the Dayquil, has chlorpheniramine in it. So we see that both of those are there. And it's keep in mind that the ones that say non-sedating, they can be sedating, but a lot of times the day preparations will have chlorpheniramine in it. Drugs like Dimethane have bromophenariamine. We see that a couple of others, cyproheptadine is typically prescription. It's also known as Periactin, a lot of times used for chronic or severe itching. And then promethazine is Phenergan, which is actually used as an antiemetic and a drug for treating nausea. So these are sort of the drugs that are acting primarily as H1 antagonists. So what do the H1 antagonists do? They're going to block the effects of histamine that's released from mast cells. So typically when the mast cells release histamine, we're going to get bronchoconstriction. People are going to have difficulty breathing. We see this in anaphylaxis. We see the immune and inflammatory responses are mediated by H1. So this is what we're going to use, is these H1 antagonists are going to be used primarily to offset these type of actions. So during allergy season, you know, a lot of pollen out this time of year. A lot of people start taking antihistamines, and the reason for it is they're trying to block that histamine release that's occurring because due to the pollen. Many of these agents have, it's interesting to know, is probably, is most people would potentially recognize that these are have sedative effects. Just as an FYI, I have been called over the last several years by individuals that have been pulled over and been charged with driving under the influence. So one of the things that's happened is someone has taken their allergy medicine, and Benadryl has been one of these, and somebody's taken it and they've ventured out of a lane, maybe rolled through a stop sign, some offense, and they've been checked for drugs. They've given consent, and that diphenhydramine has come back. And so diphenhydramine is then, they are charged with driving under the influence, which a lot of these individuals, that's that's not the case. A lot of these drugs will have, in addition to being antihistamines, they have antimuscarinic actions. Those antimuscarinic actions can be helpful in the sense that they help dry up secretions. So that's a positive thing. Some of them can have some anti-serotonergic, and some of them can actually have local anesthetic actions. So these other effects can all contribute to some of the beneficial aspects of these antihistamines. But we have had some antihistamines that were that have not done well. For example, let me go back to this previous one. I think Seldane was actually pulled off the market, if I'm not mistaken, because of some issues that are associated with arrhythmias, heart arrhythmias. But these other things is that, for example, Astimazole, one of those Astimazole, some people like it because it's not as sedating and it apparently doesn't have the interaction with alcohol. When I say interaction with alcohol, it's not that it interferes with alcohol's metabolism or anything like that. What I'm saying is that basically Astimazole doesn't produce this CNS depression. With most of these antihistamines, we're concerned about alcohol. In particular, people that drink and take an antihistamines, it can produce a greater sedation. So, for example, in things like NyQuil, you've got alcohol and you've got an antihistamine. So the two of those can potentially produce sedation. Throw in that you may also have dextromethorphan for a cough suppressant. That can also produce some sedation. Phenindamine can actually stimulate the CNS. And this is true for several of these drugs. For example, in children in particular, Benadryls can sometimes become a stimulant more so than a depressant. And so sometimes when kids get Benadryl, what we see is they're bouncing off the walls. We don't really have a good explanation. It's not predictable. But we even see some adults when they get antihistamines, they may have pretty, excitable type behaviors. As I said before, if it's, if there's prominent anticholinergic, primarily when we talk about anticholinergic, it's antimuscarinic. What that can do is it reduces the salivary and bronchial secretion, so it sort of dries people up, and that actually helps. But if you're dealing with an asthmatic, one of the problems is drying up of those bronchial secretions can actually precipitate the asthma attack. So we have to be careful there. Some of these drugs, because of their anticholinergic actions, they may, remember yesterday we talked about scopolamine being used for motion sickness, and that's due to its antimuscarinic actions up into the central nervous system. And actually some of these drugs like Phenergan can do that, can be helpful for motion sickness. We also see that, so that's Phenergan, but we may also see the sedative effects that individuals experience can sometimes help with that. Now, the problem is that when people have motion sickness, obviously some people, if they're traveling with someone else, those individuals, being sedated and being able to sleep, may actually, they've got their eyes closed, they may not feel the motion sickness, they may not get the stimuli that's there. So these anticholinergic actions can actually contribute to that. The fact that they have serotonin blocking activities really doesn't give us any advantage of these antihistamines, the ones that have it versus the ones that don't have it. So when we use it, look at their major uses is there's a number of things that you probably already know that they use. One is that for hay fever. So people will use antihistamines to try to prevent or to relieve allergic rhinitis, which is the runny nose and the stuffiness that you get. Urticaria, any of the itching, a lot of times things that cause itching, the itching is actually produced due to the release of histamine. So that can be, these drugs are very effective for that. We do have some that can be applied topically, and Sometimes that's a better way to go, especially if you're worried about sedation with these age. Insect bites respond pretty well. As I said before, the insect envenomation usually occurs and causes a release of histamine, and that's one component. And so by alleviating the histamine effects, then that helps with that. Asthma, we have to still be careful because especially asthmatics are more susceptible. Their airways are hyper sensitive. And but because of the anticholinergic actions, we have to be careful because it can actually make it worse. And then we do see these used for motion sickness, Phenergan in particular. I think cyproheptadine has also been used, but Phenergan is probably the one that was used. We probably see scopolamine used more frequently than these drugs. But when you look at over-the-counter preparations, and I'm not talking about supplements, I'm talking about over-the-counter drugs, typically the ones that are identified for sleep aids, things like Unisom and things like that, they typically are going to contain either diphenhydramine, pyrilamine, or doxylamine. And typically we see most of them will either have diphenhydramine or doxylamine in these over-the-counter sleep aids. So be aware of that. Be aware if any of your patients are using those and maybe taking drugs that you're prescribing that may have antiadrenergic actions. This could be more of an issue with more sedation. So be aware of that. Jason, you asked the question, is the non-sedating type because they don't cross the blood-brain barrier? They will. I mean, most of these non-sedating drugs will be sedating. They're just not as. So it's basically that their affinity for the receptor is a lot less. The big thing about most of these antihistamines is that they have a very wide margin of safety, which means that they can be used quite easily with a number of these, with other drugs, and they can be used. But we do see people that will go much further with these. One of the things that we find is that from a standpoint of this margin of safety, typically we're going to see something like 50 milligrams used, but we do see people that sometimes they'll develop a tolerance to it or it doesn't work as well. So what happens is they start taking larger doses. We do see people have started abusing Benadryl in particular, or the diphenhydramine, and what we're seeing is those individuals are taking huge doses of these drugs. So it's kicking on up to something like 150 or so. So, Kara, when you ask about what do you give with the people with the asthma and allergies, is basically you're going to control the allergies, and you're going to go with drugs that have less anticholinergic type drugs. But typically, if you can, you're going to try to eliminate as much exposure to allergic things. And what they're going to try to do is they're going to use instead, they're going to try to use these drugs, which we'll talk about when we talk about treatment of allergy, which I think will be the next weekend. You're going to use less antihistamines, and you're going to be using other situations which you're going to use other drugs which are going to act at a different site but will still interfere with the allergic response. Typically, we're going to use other antagonists of the cytokines. So that's the case. Let's see, Joy. Let me read your question here. With the atropine, they do see the atropine used for, in just like in human medicine, we're seeing it used in vet medicine also. So we're seeing less used of atropine used for dilation and so forth. What they may have done is given your dog the atropine to somewhat maybe to cause dilation and help the ulcer and everything to dilate down. Okay. All right, getting back to the antihistamines here. Oh, jumped too far. Typically, these are going to, like I said, have a wide margin of safety. So when we start having, the most common side effect we typically see with these drugs is going to be sedation. So what we're going to see is that even with the wide margin of safety, we have to be very careful with combining it with any other CNS depressant. So alcohol, barbiturates, benzodiazepines, those are 3 classes of drugs, but even some of the antidepressants, because again, and even antipsychotics, some of those antidepressants and antipsychotics are going to produce some or have antihistaminergic effects in them. So that would be an additive to that. So one of the things you want to do is caution your patients about using these over-the-counter drugs that may contain a histamine in it, antihistamine in it, okay? Now, when we see people that either have taken a large overdose, what we typically see is going to be that the symptoms are very similar to what we see with atropine. You get a lot of CNS excitation. You can also have some convulsions. But primarily the CNS excitation is going to be a big issue. A lot of times these drugs are used, but anytime you use any drug on the skin, you can get some contact dermatitis. So even though we're using it sometimes to treat some of the signs or symptoms of contact dermatitis, then we're going to see the potential for this occurring. So be aware that sometimes when you're putting anything on the skin, there is the possibility for producing some types of contact dermatitis. So that's sort of the H1 antagonist in a nutshell. Just sort of to summarize them before we move to the H2. So with these drugs is basically what we're going to see is that the itching, the inflammatory responses, the allergic the reasons for treating this, these are mediated all by histamine. And what we're doing is we're basically blocking the effects of histamine, and specifically we're blocking the H1 receptor. So remember that. So the vasodilation, the edema, the itching, all of that is mediated through the H1 receptor. So we use these antihistamines. It is a competitive blockade. These drugs, many of them are available over the counter. Many of them, we do have some prescription medications that are antihistamines that are like, for example, cyproheptadine, Phenergan. Those are prescription medications that can sometimes be used. Keep in mind, a lot of the drugs that you may prescribe, some of the antidepressants and antipsychotics can have these antihistaminergic actions. And so sedation is usually our biggest concern with these particular agents. Again, they have a fairly wide margin of safety. And basically, even with that wide margin of safeties, you can get some issues. The other thing I try to tell patients and tell my students when they're dealing with patients is realize that these antihistamines, while they're in a lot of over-the-counter preparations, they can cause significant sedation and people can be charged with DUI. So that's one of the big things we're there. Kirsten, you were asking about the Kenalog shots. All right, so when we're talking about Kenalog, let's see. I want to make sure that the Kenalog doesn't have anything else in it. So the Kenalog is basically, this is what I was making sure, that it was just a steroid. I can't remember if the Kenalog had anything else in it. But what we find is that for allergic and for allergic type responses, steroids work pretty well. And with the steroids, what they're going to do is they will basically decrease inflammation. The problem with steroids is the side effect profile is typically more of an issue than we see with the antihistamines. The steroids may be a longer acting than the antihistamines, but the steroids can have a lot more interactions with a number of other things. So we used to use steroids quite a bit for a lot of different things for inflammatory conditions. But one of the problems with steroids is that basically those steroids can, for example, cause osteoarthritis and so forth. So Brady, so with regard to the H1 antagonist, just to sort of summarize this up, So what we find with the H1 antagonists, basically histamine is the mediator of a lot of the vasodilation, which causes the redness, the itching, and discomfort, the swelling that occurs. Histamine will cause vasodilation, which causes redness, and also it causes the capillaries to become leaky, which causes the swelling around it. The swelling puts pressure on it in the area, which can cause some pain. We also see the mast cells can get damaged during those inflammatory responses. The mast cells release the histamine, which sort of makes it worse, causes the itching. So, and of course, one of the things that happens is when you get a bug bite or something like this, all of us have been told, is one of the things that happens is when we, what literally happens is when we scratch, a lot of times it feels better. But what will happen is when we keep scratching, basically what will occur is that you will break the skin and then you can get some bleeding and possibly get some infection with it. So what we do is the antihistamines alleviate the effects of histamine, which decreases the itching, which decreases the swelling, which decreases the redness and sort of helps. Again, we're using these drugs and so they will wear off. And we see people using these for example, with older people, their skin gets very dry, and the dryness of the skin can as it sort of gets flaky and everything, it can cause histamine to be released. And so people will scratch their legs. So one of the things that happens is that they scratch their legs and start, get itching and sores and scabs. The more they scratch, the more they bleed and that type of thing. So sometimes what we try to do is use something like a lotion to keep their legs moisturized so that alleviates the dry skin. But sometimes if the itching is really, really bad, then we can use an antihistamine. And the antihistamine will block that. And sometimes the sedation makes them sleepy. So they may go to sleep and may not, be awake and feeling an itch. So that's it. So they have a wide margin of safety. We use them for various different things. Sedation is probably the most concerning side effect that we have. And with sedation, basically what's going to happen, so many people may just get a little bit sleepy, but we've taken advantage of that because we do use over-the-counter doses of these drugs for sleep aids. People can develop a tolerance to them. And so we have to remember that these drugs basically are going to be only for a limited time. They're really, that's about what they're used for. Some individuals will respond with excitation. They do not respond with the sedation. So we do, children in particular, we do have kids that will, you give them this and it bounces off the walls, and sometimes that is more and more of an issue. Can we predict which child is going to, be hyperactive? No, we can't. I did a continuing education program with a pediatrician, and that question came up, and he did not have an answer to it. He said some people may say, well, sometimes it may, by blocking the inhibitory pathways or stimulating the excitatory pathways, that may account for it, but I don't have a good explanation for it, and I'm not aware of anybody that has given it. Your biggest concern is also remember that several of the drugs that you prescribe may have antihistaminergic properties, and those antihistaminergic properties combined with antihistamines can have a greater effect or greater blockade. And in particular, you worry about sedation. So if you're prescribing an antidepressant or an antipsychotic that has antihistaminergic properties, then you got to be careful about it. One other thing is that we do know is that by blocking histamine, one of the things that you do see is that it can increase appetite. So people that are using these drugs, they may gain weight. And drugs that have antihistaminergic properties, antidepressants, antipsychotics, tend to have greater weight gain. So, one of the things to sort of put in the back of your mind is that if you block the histamine receptors, that tends to increase appetite and that tends to increase sedation. again, our biggest concern with this group of drugs is primarily the sedative aspects of it. And even the drugs that are like chlorpheniramine that are stated as being non-sedating, those drugs can produce sedation in some people. Okay? All right, anybody have any other questions about the H1 drugs? Okay, now we're going to step to the other receptor, which is the H2 antihistamines. Okay, so with the H2 drugs, these drugs have minimal effects, if any, on the H1 receptor. And the drugs that we have, most of these have gone over the counter, although physicians still write prescriptions for them. But this includes Cimetidine, which is also known as Tagamet, which we've already talked about because of some other properties of Cimetidine. It includes things like ranitidine, which is Antec, famotidine, which is Pepcid, nizatidine, which is Axid. And again, these were big money makers when they were prescription. And now they've gone over the counter, still making plenty of money because these are used quite frequently. So I want you to be familiar, primarily, we're going to talk a lot about, a little bit about Cimetidine. And this is going to be an important one because of some of its actions not related to its H2 effect. So the way these antihistamine work for gastric secretion, this is mediated through the H2 receptor. So what we find is that histamine, gastrin, which is a hormone, if you remember way back, we talked about gastrin is one of the hormones released by the GI tract, acetylcholine, and food. Those are all stimulants of basically gastric acid secretion. So if you get increased histamine release, you get increased gastric acid secretion. If you get gastrin release, increased gastric secretion. Same thing with acetylcholine. When I say food, either its presence, smelling it, tasting it, those all increase it. So the problem that we have is that when people get excessive acid secretion, first of all, we see a production of stomach acid, okay? That can result in indigestion. But more frequently, what we're concerned about is that increased secretion can exacerbate or even produce GERD, gastroesophageal reflux, because what's happening is that your esophageal sphincter is not closing completely, and the gastric acid is refluxing up into your esophagus, which doesn't have a good mucous membrane barrier to prevent burns. So one of the things we want to do with people with GERD is reduce gastric secretion, which means there's less acid that's going up there. The other thing is when you have people with peptic ulcer, is the increased gastric acid secretion is going to eat at that ulcer and make it worse. So these H2 drugs, the H2 antagonists, were found to basically be pretty effective for the treatment of peptic ulcer. And their main action was they decreased gastric acid secretion. The drugs are all acting the same way. There's a few little nuances. For example, ranitidine seems to be a little bit more potent than Cimetidine since it'll last a little bit longer. Famotidine is more potent than ranitidine, but you will find that, people will find what's on sale or somebody will recommend it to them and they will use it. So really what changed is a little bit more potency with some of these agents with basically a little bit change in duration of action. Whether the patients actually notice the duration of action, some of the drug companies will, or some of the people when they first came out would say, you could take it less. But really it comes down to people will get in their mind what works and they will use that particular group or that particular agent. All of them are pretty effective. And so again, these are used, as I said, is they decrease acid secretion, and part of it is the GERD. We use it for that. And we also, now here's an interesting thing. This NSAID-induced gastric damage. We do know, and we will be talking about nonsteroidal anti-inflammatory drugs. We talk about pain relievers. basically what you're seeing is that when we had drugs, if you guys remember, we had Vioxx, we had 2 or 3 other drugs that were called Cox-2 inhibitors, COX-2. These drugs really, when they came out, these were the Cox-2 inhibitors, which stood for cyclooxygenase. They inhibited cyclooxygenase. And the thing about them is the theory was that by inhibiting the cyclooxygenase 2, that all of the effects were where the inflammation was. And what they discovered was that the idea there was if you had a drug acting on Cox-2, then they were specific for inflammation and they were not affecting the Cox-1, which could be involved in gastric acid or the maintaining of the gastric lining and so forth. So these all came out, but then we had a problem. Number one is we saw that, yes, they can still cause some damage to the GI tract, not as much as the older drugs, the non-selective drugs, but we also found that these drugs like Vioxx was pulled off because there was an increase in heart attacks. So that left the clinicians basically looking at using the non-specific drugs. And so what they did was, what they've started doing now was they will prescribe these for people that have to be on non-steroidals for a long period of time. They will prescribe them, and that will, excuse me, so that will protect the GI tract. So that's what they're doing now, is when somebody is going to be using these drugs for a long period of time, they're going to basically give them an H2 antagonist. And it seems to protect the gut pretty well, okay? Now, these drugs, like any other drug, is going to have a side effect. What we see is cimetidine seems to have the worst profile. We've seen, and one thing to be aware of, especially in the elderly, we've seen confusion. We've seen some dizziness. So people don't think of an H2 blocker as producing some CNS type actions, but we have seen it. We've also seen some rashes that have occurred and some myalgia, which is just that basically their muscles hurt. The other thing with cimetidine, which is sort of unique, is that cimetidine actually has some anti-androgenic actions. And this doesn't occur with the other agents, but at high dosages, we could see some gynecomastia and impotency occurring. So it could affect sexual function. It could also affect, could cause breast growth in males. This doesn't occur with the other drugs. And again, cimetidine's been out longer for the other ones, and that is a concern that could occur. And again, this is usually at higher dosages. It's rare, but it can occur at high dosages. And it's one thing to consider if some of these other actions come up. And the big thing about cimetidine, which you guys have heard me tell about before, is cimetidine will inhibit cytochrome P450. Wow. So this is a big concern here, is that we can have an interaction, a drug interaction, by inhibiting cytochrome P450. That decreases the metabolism. Drugs that it's been identified with is some of the beta blockers like propranolol, labetalol, metoprolol, all of those, theophylline, phenytoin, lidocaine. The other anti-H2 blockers do not seem to affect drug metabolism. So they are preferred. We do see people taking cimetidine, don't really have a problem with it, but I usually tell people that number one is my students, I'm going to tell them, make sure you check to see if someone is taking, whether they're taking any over-the-counter H2 antagonists, and specifically if they're taking cimetidine or Tagamet, be aware that it could be affecting drug metabolism. With these drugs I've got listed here, people have been suggested to reduce the dosages or to monitor closely. Frankly, what I try to do is tell people just to avoid cimetidine because of the potential for its side effect profile is a little bit more of a problem, but more importantly is because of its effect on cytochrome P450. All right, so that finishes us through the H2. So the rest of this today is going to be focused on, I'm going to probably give you at lunch, I'm going to probably give you a couple of videos that deal with histamine. But this is a good place for us to take our break. This will be our first break. So let's come back at 15 after the hour. And then what we're going to do is we're going to pick up, first of all, is during this break, if you'll just sort of look over if there's anything else you want me to go over about the antihistamines, then we'll cover that when we come back. And then what we'll then start talking about is drugs used for treating blood disorders. Okay? So come back at 20 after, let's make it 20 after the hour. And then we'll pick up with the next group, which should be the blood disorders. Okay, guys, we're back. Just checking to make sure everybody can hear me. And let me just bring up a point that, let's see, that that Jason made earlier, which was dealing with the non-sedating it. The new drugs like Zyrtec, Claritin, and those type of drugs, they are less sedating. And the reason that these newer drugs, which are more popular, that we see, those drugs are, they just can't, they can't penetrate the CNS. So in a sense, Jason, what you're talking about is with these new drugs that we're looking at now that a lot of people are using, the Zyrtecs and the Claritins, those are non-sedating or less sedating because of that. They can produce sedation in some people, but it is just one of those, it's one of those things that, again, is if I had a choice of choosing those drugs, I mean, what I usually do is I will take something like Zyrtec or Claritin because you can take those during the day, and most people, you're not going to see much sedation with those. So that's just one of the things that I wanted to clear up there. The older drugs and so forth, the chlorpheniramine is less potent. It probably can't cross the blood barrier quite as well as the Benadryl. Benadryl definitely gets across. But again, what you're seeing is most of the newer drugs that we're seeing, and you know, if you go to a pharmacy, you can find, or to a drugstore, or to a grocery store that, you know, carries a medical thing, you'll see a lot. You may see a lot of these other drugs that are around, but pretty much they're not going to be. You're going to see mostly what you're going to see is for these H1 blockers, it's going to be Benadryl, dicyclamine, which is dealing with the, that's probably the two that are used the most for sleep. The rest of them is for allergies and things like that. Most people are pushing things like Claritin and Zyrtec versus some of the others. You still see some older people that are just, you know, they've always used Benadryl, and they're going to, I mean, I see that a lot of times, and a lot of these cough cold preparations will have Benadryl in them, but you can have a few of the other in fact, I don't know of any cough cold combination that's going to have like Zyrtec or Claritin in it. It's typically going to be doxycycline or chlorpheniramine. I think there's a couple that may have brompheniramine, but most of them are chlorpheniramine and Benadryl or doxycycline. And they usually are going to have, many of them have alcohol in them. The Dayquils and the ones used during the day are going to have less alcohol in those, if any. Okay. And fluticasone. Now, see, I'm reading your writing there and trying to say out. Fluticasone basically is going to be that is used, and it is a corticosteroid. So one of the things that you find is sometimes people are thinking that they may be antihistamines anytime they're used to dry it up, but the fluticasone, that's basically Flonase, is a corticosteroid. And Abdullah, you're right. Those are the second generation blockers, Allegra, Zyrtec, and Claritin. I couldn't think of Allegra, but Zyrtec and Claritin, these considered the second generation. That's correct. Okay. But one of the things, as you brought up, as a couple of you brought up, is sometimes for use these allergic type responses, we will see their intranasal administered, you know, the intravenousous corticosteroid. The idea here is to limit systemic absorption on that. Okay. All right, so let's and by the way, Marissa, I sent you a file. If you'll post it for Moodle, that one is, I figured you'd already got it posted there. So guys, at lunch, so we will stop like we did yesterday. There will be a brief period from a standpoint of for you guys to take 4 questions, and then what we will then I've got 4 short videos there. I think only like a couple of minutes each, that deal with the, one is the inflammatory response. There's 2 on antihistamines. And then there's one on when I say antihistamines, the H1 blockers. And then there's one on the H2 blockers and how it interferes with secretion. Okay. So that's what we're going to do when we break for lunch. And that will be probably in a little bit, maybe a little over an hour. All right. So let's move to the drugs that are used to treat blood disorders, okay? Now, in this group of drugs, we're going to primarily hit two major groups. We're going to hit the ones used to treat anemias, and then this afternoon we'll be hitting the drugs that are used to treat coagulation disorders, okay? All right. So just as a review, one of the reasons I don't have this in red is the drugs that are used for treating anemias, which I've categorized as basic anti-anemic drugs. One of the things that we're looking for is that the red blood cells basically are necessary to carry oxygen to the different tissues, okay? And their ability to actually carry that oxygen is going to be dependent on, one, whether we have an adequate number of red blood cells, and two, it's going to be dependent on our hemoglobin. And so our body is going to be required to be able to synthesize hemoglobin and be able to use synthesize the stromal proteins. These are the proteins that actually are the hemoglobin is supported with, and so forth. So what we see is anemia. I got anemia results in. It's really these things can cause anemia. So one of the things can be chronic blood loss, which is more common than you might think. And the reason for that is with chronic blood loss is a lot of times this is dealing with internal bleeding. The number one culprit basically probably is GI bleeding. So what is happening here is, especially in older people, they develop ulcers. It can happen in younger people too, but they develop ulcers. And in older people, their pain responses are not as, may not necessarily be as acute. So they may not actually experience too much pain, but what happens is over a period of time, they are going to, they're losing blood because of ulcers, peptic ulcers or duodenal ulcers. One thing that can happen is chronic blood loss can result in anemia. So this should probably, anemia results from would be a better statement here. Another reason is that there can be something wrong with our red blood cells. They may be abnormal in their shape, size, and as a result of that, their function is reduced. We see nutritional deficiencies. Going back to the chronic blood loss, another reason we see this is people that are that have chronic disease that have been taking a lot of non-steroidal anti-inflammatory drugs, and those NSAIDs may actually have produced gastric ulcers or peptic ulcers and caused bleeding. Nutritional deficiency, which we don't think about as much in this country, or when we do, we think of it as in the extremely poor, but the nutritional deficiency can also occur in fairly well-to-do people, in the upper middle class and the upper middle class and even the rich, because of fad diets. We see a lot of different fad diets that come out that can result in some deficiencies. And also this can occur due to some sort of chronic disease or malignancy. Eating disorders, Kara, is another one that can occur that people don't think so much about anemias with eating disorders. That isn't the first thing that comes to mind, but the eating disorders can result in liver dysfunction and so forth, and can ultimately affect the formation and processing of the blood. So just a quick review on since anemias primarily focus on, we focus more on the red blood cells. Remember that your red blood cell is going to, has got a fairly short lifespan. Most people suggest red blood cells live about 120 days. So you're looking at about 4 months, 3 to 4 months. One of the things, think about when the red blood cell is flowing through the blood is it's subject to a lot of different forces. One is just shear stress as it's bouncing along, rubbing against other red blood cells or rubbing against the wall of the endothelium. And then when it gets down to the capillaries, those red blood cells basically have to bend to get through the capillaries. So I think of them as somewhere along the, I think of like an inner tube, like you would have in your pool. And if you see it, you can twist it and it will bend and so forth. But that bending, every time it goes through these capillary beds, that bending and twisting that occurs eventually works to sort of wear the red blood cell down. So just like you get old, you lose your flexibility. I know when I go to do the warm-ups and certain things that when I go to martial arts, it just gets me, like one of the girls that's in my particular class was had her knees bent completely under her and her elbows stretched flat to the floor. So she was laying flat that way. And I was thinking that would probably pop every ligament I had in my knees, if not my hips. So just like we lose our flexibility as we get older, the red blood cells do also, okay? Now, the other thing that's important is we got the red blood cells that are going to carry the oxygen, but we also have those red blood cells have to be replaced. And so what's very important is the erythropoietin. We refer to this a lot of times as EPO. And the erythropoietin is going to be released by the kidney. That's the major site of it, although some of it may be produced in the liver. So EPO is released by the kidney when it sees that there's a decreased blood oxygenation. And that decreased blood oxygenation can be due to either an actual reduction in oxygen, but your red blood cells are normal, or it can be that you've reduced the red blood cells so that the overall oxygen is reduced because you don't have enough red blood cells to carry that. So what happens is that when EPO is released by the kidneys, that stimulates the bone marrow to actually form some new red blood cells. So that puts it into perspective of two other organs that we have to have functioning is one, we have to have the kidney has to have normal function so that it's producing EPO. And also we have bone marrow, which is actually producing it. The bone marrow needs to basically be able to produce that. Some people that have chronic anemias is that we see that sometimes the bone marrow just gets worn out. The bone marrow gets, because it's producing so much red blood cells in response to a deficiency, trying to make up for that deficiency, it can sometimes get worn out. So we have to have, red blood cells. We have to have the kidney, normal kidney function, the liver function to help manage the iron, the hemoglobin, the different proteins, and the bone marrow with regard to being able to be stimulated and produce red blood cells. So for a blood cell to mature to the state where it can actually carry oxygen, there's at least 3 nutritional factors that are required. We have to have iron, because iron is going to be very important in that. We have to have vitamin B12. We have to have folic acid. So if we are short or deficient in any of those 3, for example, we'll talk about pernicious anemia. And with pernicious anemia, one of the problems is that the body can't absorb vitamin B12 because it's missing a component called intrinsic factor. So if the intrinsic factor is not present in the stomach, then you can take all the B12 you want, it's not going to be absorbed. So that's why we have to give people that are missing, that have pernicious anemia, we have to give them injections or give it nasally. We can't just give it orally. So looking at iron, let's take a look at iron, because we'll talk about iron deficiency anemias, and that's one of the ones that we can correct fairly easily. Your body basically is going to use about 70% of the iron that's in your system, okay? 30% of it is going to be sort of stored, or, it's not going to be, it's going to be present and we can use it, but pretty much 70% of it is actually functional. Most of the iron is going to be in the form of hemoglobin, okay? The rest of it is stored. We talked about this in clinical medicine. We see it stored as hemosiderin. We see it stored as ferritin. In blood, it's bound to transferrin, which is actually a carrier protein. So what happens is when a person starts getting a depletion of hemoglobin, for whatever reason, basically the body starts mobilizing the iron from the tissue stores. And it can actually replace about half of the circulating hemoglobin. So if we lose half of our hemoglobin, your tissue stores of iron is enough to replace about half of it, okay? Now, when I was growing up, if you were male, all of the kids' vitamins in particular, but then when you started, even with the one-a-day vitamins and everything, what we actually saw was iron was a big thing. The concept was that men needed the iron because they had bigger muscles than women, that their body, the iron was necessary for them, to be strong and so forth. So we saw almost every male vitamin back, especially, 50s and 60s for sure, and going into the 70s, almost every male vitamin product had iron in it, fortified with iron. What we discovered is basically that extra iron could actually be dangerous. And what we started seeing was males in particular who were taking in a lot of iron, who didn't necessarily have iron deficiency, but the idea is that the thought was back then was that we needed the iron because we were working all the time and our red blood cells were working. And so what we discovered is that people taking a lot of iron supplementation that did not have a deficiency, and I say people, men in particular, iron resulted in a greater production of free radicals, and those free radicals could cause cancer. So what we saw is, probably in the 80s and 90s, there was a big move to reduce the amount of iron or take all the iron out in men's vitamins, with the idea that if men were deficient, then you could give them iron, but you did not want to give them excess iron. And the reason for that was that there seemed to be a link that excessive iron in males could produce free cancer due to generation of free radicals. Now, the other thing too that a lot of people thought was with men is they always thought of men eating a lot of red meat, so that we were probably getting more than enough iron in our body through our regular diet. Rebecca, I see that you are seeing a little bit of loss in sound. Is anybody else having a sound problem? Okay. Well, I moved the microphone a little bit closer just to see if that might help. But just let us know and see if that gets better. So one of the things is that we see iron supplementation frequently in pregnant women and children because they're growing and they're producing it. So, and then we can see iron, if somebody develops an iron deficiency anemia, then we're going to give iron. So let's look at that we have plenty of products that have iron in them, but if we cannot get enough iron in our regular diet, then we're going to do iron supplementation. Now, the interesting thing about iron is where does iron get absorbed? It's primarily in the intestine, small intestine. And what we see is the duodenum and the jejunum. The duodenum is the front part of the small intestine, whereas the jejunum is sort of the middle. What you see there is that the mucosal cells of those two areas of the small intestine actually will take up iron. But those mucosal cells take up the iron, but they don't actually transfer all of that to the blood. In fact, what we find is only a small amount is actually carried to blood. So what we find is that it's an interesting thing is that those mucosal cells serve as a storage site. So if we start developing a deficiency, then those mucosal cells will release or allow iron to be transferred from them. And basically, it can be taken up in the bloodstream. But if we don't need it, then what happens is the mucosal cells, and iron is stored as in its form as ferritin, but we have iron that stays in the mucosal cells, and if we don't need it, then basically those mucosal cells turn over fairly frequently. So what we find is the mucosal cells slough off when they get old, and the iron in the mucosal cells just goes out the intestine and goes out through the feces. But when those mucosal cells are viable, if we need iron, there is a storage site that we can pull iron from. And then when the new cells are replaced, or the old cells are replaced by the new cells, then the new cells will sequester iron and hold it until they're sloughed off. So the iron gets absorbed in the ferrous state, which is the 2+ state, okay? What determines how fast it's absorbed and how much is absorbed is the gastric acidity, the amount of vitamin C in the diet, the food intake, all of those come into place. Things that can interfere with iron, one is antacids and phosphates. If people are using a lot of these because they have indigestion and so forth, they can actually interfere with the absorption of iron. So somebody that's using a very, very lot of antacids, one of the things they can do is they can develop somewhat of an iron deficiency that occurs. The other thing happens is if you've got a lot of iron, so you've taken a lot of iron, basically it's sort of a feedback system, or your bone marrow activity is decreased, then the body is basically saying, I don't need to bring this iron in, so it's not going to absorb as much. But if we have any situation where that the iron intake drops, the body's going to try to get that, or if the bone marrow activity increases, then the body's going to want more iron. So it's a negative feedback that will move the iron or transfer the iron into the system where it can be used. We're very good about actually conserving iron in the body. Like I said, we got those mucosal cells, we have the tissue storage sites, and so pretty much we have those stores necessary if we need to use them. The other thing is our body is basically recycling the iron. So when the red blood cells break down, basically the liver then will degrade the hemoglobin, and it will actually pick up the iron and then recycle it. So the body is pretty good about recycling what we have here. We really don't need the estimated daily requirement is only about 1 milligram per day. And if we're eating a normal balanced diet, we're going to probably take that in. Now, some vegans may not take that in. You may do some supplementation on certain diets that may be required. We do know that our body is going to have an increased need for iron when we're growing. That's one of the reasons children in particular may be subject to some iron deficiencies. Women in particular, during their menstrual period, they're going to lose blood. When they lose that blood, they're going to lose iron. And with pregnancy, we have a growth there where the fetus is growing, so the mother is going to need some additional iron to accommodate the fetus. But so we're pretty good about not developing a deficiency. But when we do, what happens is that if someone develops a deficiency, it is very difficult for those individuals to replenish the stores just with a normal diet. So once a deficiency develops, then pretty much what we have to do is we're going to have to replenish the iron with some sort of supplement. So let's talk about iron deficiency anemias. This is a little bit of a review from when we talked about this during the clinical meds course. Where we typically see this iron deficiency anemia occurring is we see about 1/4 of the infants will develop it, and their growth is just not keeping up with their intake there. Much smaller percentage of young children, roughly about 6%. 15% of menstruating women due to their loss in their periods, and about 30% of pregnant women will have, that's the estimates of what we would see with developing an iron deficiency anemia. So what you're looking at is children, infants, children, menstruating women, and pregnant women. Women athletes can be at a high risk. Now, some women, when they're with the athletic women, their periods will almost become non-existent, so they're not going to lose that. But depending on with their menstrual period, if they're having it, and then with their normal, very athletic activity, they may have an increased destruction of red blood cells and turnover of red blood cells, and that can sometimes result in the iron deficiency anemias. So what we're going to do is we're going to diagnose this based upon looking at, many times what we'll see is that individuals will, we can pick this up with the CBC. and they will have certain symptoms. So what we're looking at is typically an iron deficiency anemia. The blood cells will be microcytic, so they'll be small. So if we do a complete blood count, when they look at the red blood cells, they usually do a blood smear. When they do that, they can see the red blood cells. So what happens is that in an iron deficiency anemia, the red blood cells are small, microcytic, and they're hypochromic, so they're pale, mainly because they don't have the iron there and the hemoglobin to give them the red color. The individuals usually will present with having pale skin. Common symptom is they're fatigued. There may be a loss of appetite. And a lot of times the paleness and fatigue, most people will say, well, that person may have an iron deficiency. Now, that may or may not be true. But one of the things that you might want to make sure for is basically that some of the symptoms can show up as people that are depressed. Not eating, fatigued, tired all the time, those type of things. One thing you want to do is rule out whether there is an anemia, and that can be done fairly easily by a complete blood count, which can look at the red blood cells and they can pick that up pretty quickly. But you can also measure iron and some of the iron transport proteins to see if there's any issue there. You can measure hemoglobin content. So these are all things that can be done with blood work that can identify this. We do know that supplementation will work really well for these iron deficiency anemias, okay? But the thing is, the key point here is that these iron stores are going to be replaced slowly, okay? Typically, you're looking at, to get back up to normal, it may take about 6 months, maybe even a year. One of the things is you can't just give huge amounts of iron. That can create some problems. Your stomach won't tolerate it in the most part. So that's why it's typically, for example, in pregnant women, we will typically supplement with iron to try to get them from doing that. Now, there's a number of what we use is iron salts. These are called ferrous salts. And there's a number of oral preparations. We have ferrous sulfate, we have ferrous gluconate, we have ferrous fumarate. So different people will have different, you'll find that individuals will have a preference. The treating individuals will suggest this. Sometimes it may be that a person will tolerate one of the supplements better than the other. One of the things that we see in infants, newborn infants, is that we frequently are going to see a situation where that they may be suggested they be put on an iron-enriched formula. These iron-enriched formulas a lot of times can be irritating to the baby. And so two things that you see parents complain about is, one, a lot of times the baby will have more, colicky type pains. Their little belly will hurt because the iron is not there. And the other thing is, a lot of people will say putting them on those irons is their stool really becomes really stinky. But with these preparations, what you find is that this is why it takes such a long time to replace the iron, is that about only 15% of the iron that's there will actually be absorbed. So you're not going to absorb a whole lot, okay? Most common thing with these iron supplements is GI irritation. And so that can be, a lot of people, we try to prevent really iron by in these groups to maybe give them an iron vitamin, which is a little bit easier on their stomachs. But when we start using these ferrous salts, this is a real concern. Probably the biggest things we see is, when I say GI irritation, is a lot of people complain of abdominal cramping and maybe diarrhea. People would say that they get nauseous, their stomach hurts. Some people complain of headaches. What we prefer doing is to limit or to minimize the GI irritation. Is a lot of times we give it after meals. So we get their stomach, get something on their stomach, and then give them the iron supplement. We see more of the GI problems when they're taking it on an empty stomach. We don't like giving it parenterally by injection, parenteral. That can actually produce an iron overload, and there have been reports of anaphylactic shock, so we don't do that. Adults usually are not going to show a lot of toxicity. They may show the stomach irritation and so forth, but one of the things that happens is if an adult tries to take a large dose of the iron, typically it's going to cause them to vomit, and so that's one of the ways your body gets rid of a toxin. And the body is saying, this is too much, it's sort of toxic, so they throw it up. So adults rarely experience severe toxicity because their body just won't absorb it. They throw it up. Children actually can be at risk. They can actually overdose. We have had instances where, some of these fruity vitamins like Flintstones or whatever made for children, we've had kids get like a bottle of that and think it's candy and just eat a lot of it. So we see that basically there is a chance for severe toxicity in kids because they don't show for some reason they don't produce as much vomiting that adults do. But adults, when you're an adult, your stomach seems to recognize this and get rid of it a lot quicker than with the kids. And part of it may be that the kids, the way they may take it, which would be through one of these, flavored vitamins or something like that, may not produce the irritation and the nausea like you see with the adults. When we do have an overdose, we use a drug called deferoxamine. And deferoxamine is a iron chelating agent. So what it does is basically it is water soluble. So what it does is it basically circulates around in the blood and it will trap the iron. So when we talk about these chelating agents, what these are basically they bind to the iron and prevent it from being absorbed. And then what happens is basically you excrete it. So what the iron does is it basically traps any free iron that's going around, and also any iron that's bound to ferritin. It will bind it, prevents it from being chelating agents. Think of them as sort of a sponge or a trap that will trap the agent and then trap the iron and keep it from being absorbed. So deferoxamine is a drug that we use for treating iron overdose. So if somebody, like a child, came in and had just eaten a whole bottle of Flintstone vitamins, we would see that we would use the deferoxamine. Okay. All right, let me cover this next slide, and then we're going to take just a short break, be our last break of the morning. So another type of anemia is megaloblastic anemia. And what megaloblastic anemia is this is due to either a deficiency of B12 or folate, okay? Now, it is very important to determine where the deficiency is. So when you have megaloblastic anemia, regardless of whether it's B12 or folate, it will respond. In other words, B12 deficiency will respond by giving B12 or giving folate. A folate deficiency will respond if you give B12 or folate. So the anemia will actually respond to either one of those. But what you have to be careful about is if the deficiency is due to B12, although the blood anemia, the blood portion of it, responds to folate, the lack of the B12 can result in neurological damage. So it's important to determine the cause of the anemia. So, for example, if you have a B12 deficiency and you give folate, the blood part will respond. But what will happen is the B12 deficiency, you need B12 for neuronal activity. And what will happen is that you will get some neurological damage by treating a B12 deficiency with folate. So it's important, when you've got this, both of them may show similar characteristics, but if you don't correct the B12 component, then you're going to have some neurological things. And the way we're going to treat B12 is we're going to give cyanocobalamin. Okay. Now, when people develop, when they have a B12 deficiency, we call this pernicious anemia. Okay. So what's going to happen is cyanocobalamin has got to be converted to methylcobalamin or adenosylcobalamin. And it's important, this is a key point, is you have to have intrinsic factor in order to absorb it, okay? So people that have pernicious anemia, they do not have intrinsic factor, which means that you can give them all the B12 you want to orally. It's just going to go right through them. It's not going to be absorbed. So when we are treating people that have the pernicious anemia, basically they don't have intrinsic factor. The deficiency has developed because they can't absorb B12. And so what's going to happen is we have to give this parenterally. We can either give it by injection, or we can give it, there's now a nasal preparation where that you can, they can squirt it up their nose. So it has to be given that way, otherwise it won't be absorbed. When the nasal prep came out, the biggest problem was that it was so much more expensive. But the injections are fairly easy to give. The patient can be easily taught how to give an injection, or somebody in their family can do that. We will find sometimes is you need to make sure that the patient is actually, taking the medications, because I have seen where a patient may not either go get the medication or just may simply don't take it. So you need to make sure that the patient is being, if you have someone that is on this, you need to make sure that that they are taking this medication to rather than that. A lot of times they'll get irritable. You can have neurodegeneration that can occur if they continue doing that, not doing that. All right, let's cover the next two, and then we will take our last break. Next two slides. The other one is folic acid. Folic acid is very important for DNA synthesis, gets absorbed well from the GI tract. Our oral preparations do no problem. It does not require intrinsic factor. And we see when people have a hemolytic anemia, that's where the red blood cells are being broken down. If they're malnourished, chronic alcoholics will get deficient in folate. Pregnancy, during lactation, if they have things like sprue or ileal disease where they're not getting absorption, these sometimes these are the times that we're going to typically give folic acid. And basically, again, it will, if we give it and it's a B12 deficiency, then what's going to happen is it corrects the anemia, but it doesn't. What happens with B12 deficiency is the neurons start demyelinating. Folic acid will not affect that. So the big thing is, if you incorrectly diagnose this anemia and you're just treating them with folate when it's really a B12, then they can get some demyelinization to the point where you get irreversible damage to the nerves, to neurons. So we're looking at intrinsic factor is necessary for the absorption of B12, for the B12. That's why we have to give the B12 injections. If a person, when people give B12 injections, if the person is not anemic, some people give B12 because it supposedly increases energy. And if the person is not anemic, they can take oral supplementation of B12. They don't have to have the injections. The B12 injections actually may get a quicker onset, and that's why some people go to do that. But if you do not have pernicious anemia, then you can take B12 orally. And it's not the folic acid deficiency, it's the B12 deficiency that causes the demyelination. So again, what you're having here is folic acid. When you get a megaloblastic anemia, the anemia will respond to either B12 or folate. But if it's a B12 deficiency and you're given folate or folic acid, basically what's going to happen is the individual's anemia will improve, but they can develop demyelinization. Okay. All right. Let's take our last break. Let's come back at, I'm gonna give you all a weird time. Let's just come back at 10 after the hour. What I want to do is I want to introduce some normal hemostasis, and then we will break around 11:30, 11:35, 11:40, somewhere in there. So you guys will have time to take the next questions And Marissa, the first 4 questions for Sunday, you might want to go ahead and put those in a poll so that they can have those when we break just before lunch so they can take those, okay? All right, so come back at 10 after the hour. That'll give you guys about an 8-minute break. And I sent them to you and Aiden, but I can resend them. So I'll do that right now. So again, I'll see you guys at 10 after. Marissa, I'll resend those now. Marissa, I just sent you the Sunday morning questions. So the first 4 will be this morning, and then the next 4 we'll probably have about maybe 2:30, 3 o'clock or so. But then did you also get, you should have also got the post-test. Did you get that? So we'll do the post-test probably at right about 3:30 is when 3:30, 3:40 is when we'll stop. And but these Sunday morning questions, you'll have 4, the first 4, which we'll give to them in lunch when I break in about 20 or 25 minutes. And then the second 4 we'll do about mid-afternoon, and then like 30 minutes, 20 to 30 minutes before the end of class, we'll do the post-test. Marissa, I just sent you one more link with 2 videos. If you could post that also. Thanks. Okay, guys. So let's go a little bit further. Now, the last part of today, from here through after lunch, is we're going to be looking at drugs that are used for really clotting disorders. This is a big one. Number one is we'll talk about heparin, which is very commonly used. We don't see that long-term use. We're going to talk about significantly about warfarin. We're going to talk a few other drugs that are used in patients that will have clotting disorders. And so you're going to see a lot of patients. And then, of course, we're going to end up with talking about what we refer to these new oral anticoagulant drugs, which are Pradaxa, Xarelto, and those. We'll sort of finish up on that. For lunch, I put some videos. Marissa's put up a couple of about 6 things. I told you about the a couple of the things, but I've also just added one on pernicious anemia, and then I've got one on the hemostasis, which there's an animation about how blood clots, and so that'll sort of be part of what we're going to be looking at with regard to this, with regard to a lot of the mechanisms. But what I wanted to do is I wanted to introduce actually the hemostatic process before we break for lunch. So we're going to do that, and then we will let you do the 4 questions and then head to lunch. So when we're talking about hemostasis, one of the things is that we have to, our blood system is, our body is really set up to really almost be slightly skewed as being in an anticoagulant state. But what I'm saying is that we want where our blood is flowing and it's not coagulating, but we want, if something happens, that be able to plug it up quickly. So what we have is 3 processes, and when we talk about some of these drugs today, you'll see where they may interact. For example, some processes will be to be anticoagulant to keep us from clotting. Other processes will be where we can clot. So if we have damage to our blood vessel, that we can get a clot. So, and then we'll have a part that is called the fibrinolytic process, which is actually the breakdown of the clot. So typically the body stays skewed to the anticoagulant state, which means that our blood is flowing through our blood vessels. It's not clotting, but it's ready that if something happens to initiate the clot, that it can plug it quickly. So that's our procoagulation state. So we keep a balance slightly skewed towards the anticoagulation, but we also have the factors where that we can clot if we have damage, and we also have a means of breaking down the clot once healing has occurred. What generates the coagulation process is actually damage to the blood vessel, actually to the inner lining of the blood vessel, which is the endothelium. So if you cut yourself, what's happening is when you cut that blood vessel, basically what happens is it will damage the endothelium. And when you damage that endothelium we think of really as a very smooth lining that allows the blood cells to flow very easily through. And when it's damaged, what happens is one of the things is that it exposes the collagen underneath it. So you have the endothelial cell, which is very smooth and in essence almost non-reactive for the general. So when I was coming through, they described it sort of like a Teflon layer of the blood vessel. So what happens is when that gets disrupted, basically collagen lies underneath, and collagen is sort of sticky. I think of it as, I visualize it as sort of like flypaper. So one of the things that that we see happening is that the collagen is exposed, and then the platelets start sticking to it, and then you start getting a release of what we call attractant or growth factors. So literally what happens is, the idea is, if the endothelium is disrupted, then basically what's going to happen is that sets about a series of events, which we refer to as the coagulation cascade. And basically it gets plugged up. So platelets basically start sticking to where the injury occurs. They're creating a dam and making a clot, and that's sealing the blood vessel to stop the bleeding. And by the way, just a practical standpoint is, if you ever cut yourself, the tendency is people tend to wipe the blood away. Well, when you wipe the blood away, what you're basically doing is you're wiping away those clotting factors and so forth. It's better to blot. And if you blot, you don't wipe those away. So that's just a little thing that you find out a lot of people constantly are wiping blood, and it just keeps the bleeding going. And what you're going to do is, if you blot it, it will clot and stay clotted there. So what we find is that basically the platelets get there, and then we get fibrin comes in, and fibrin is sort of like scaffolding, which sets up these strands that allow the platelets to build on and to form a clot. And then eventually what will happen is smooth muscle and other cells grow in there, and they basically form the healing. Now, the downside is that, for example, when we have high cholesterol, is the cholesterol and free radicals can damage it. And so the endothelium is disrupted, and the damage, and we find clots form very similar to that. But basically, in our body, we have these components that we refer to as physiological anticoagulants and fibrinolytic enzymes, which break down any of these unwanted clots. So the idea is that when we do cut ourselves or damage, have injury, then the bottom line is what we're going to try to do is plug it up, let it heal, and then we want to break that down so there's not anything left in there. It's sort of like if you have damage to your house, you want to get up there with the scaffolding, get it fixed, get it repaired, and remove it. You just don't leave that there. So these physiological anticoagulants and fibrinolytic enzymes are circulating through the system. One of the animations you'll look at lunch sort of shows what's happening there. And what we find is drugs that interfere, or drugs that are used to treat these clotting disorders, we're going to be interfering with this coagulation process. A clot is referred to as a thrombosis, and our biggest concern is we want a clot to form when we're bleeding. But what we have to be careful about is, if we have a condition in which we form a thrombosis, that can result in significant morbidity and mortality. So, for example, when we get a clot that we shouldn't have, we can, in an artery, it can occlude, and that's what happens when we have a heart attack. Is basically we have an unwanted clot that blocks the blood flow, and what that's going to do is going to starve the tissue downstream from where we're at, from oxygen and nutrients, and we can have death of that tissue. That's what happens in a heart attack. This is what happens in stroke. It happens in the brain. The other place we see it is in your limbs, like in your legs. Lower legs in particular are more susceptible. That's where we develop peripheral ischemia. That's in the arterial occlusion. The other thing that can happen is we can get clots that occur in the veins. And when you get venous occlusion, our concern is, one, you get a lot of swelling in the veins, especially in the legs. It becomes painful because those tissues have a lot increased pressure and so forth. But our biggest concern with venous occlusions or venous clots is that pieces of those clots can break off, and those can then travel and form a pulmonary embolus. We can get emboli forming from arterial clots also. So if a clot occurs, for example, up in our heart, it can break off and go up and form an emboli in the brain. Okay, so when we find clots in the legs, those are going to show up in the lungs. And the reason they don't go up into our brain, so a venous clot is not going to cause a stroke because it has to go through the lungs, and that's where it gets trapped. Strokes due to clotting is going to be due to a break off of inside the heart or heart valve, a clot on the heart valve, or one up in the carotid artery. So those are going to occur, and then they get trapped up in the brain and cause ischemic clot there. So this thrombotic disease is going to be occurring because it activates the normal procoagulation state. The things that set up for clots is pretty thing. One is damage to the endothelium. If you damage the endothelium, that sets up for the clot. Another thing is blood flow, blood stasis. If blood is not moving, then basically slow moving blood is more likely to clot. One of the reasons why people get up, especially when they're sitting for long periods of time or on an airplane, is they want you to get up and walk around because your skeletal muscles will help improve circulation. And then the other thing is some people, their system may just be, some people have genetic components where that their coagulation system is actually going to be a little bit more active. So it's sort of overactive. So either they have increased coagulability or decreased anticoagulability. And we describe this as basically Virchow's triad. Basically what this says is there's three things that set up for clots. An increase in any one of these can actually create a problem. So one, damage to the endothelium, and that can occur due to basically high blood pressure or diabetes or things like that. Circulatory stasis, where your blood's not moving, and a hypercoagulable state, which means that either your coagulation system is hyperactive or your anticoagulation state is deficient or underactive. And what we're going to be looking at is primarily most of the drugs we're going to be looking at are going to be factored in at the hypercoagulable state. They're going to be working on the coagulation pathways. Okay. All right. This is a good place to stop because what we'll do is when we come back from lunch is that we're going to, we will start talking about heparin and the various drugs. So what I want you to do is I want you to, there is a video that Marissa's posted, deals with coagulation, that will talk about the overcoagulation state. And so let's get that one looked at. And then I think you've got about 3 or 4 other videos that you've got posted, Marissa, if I'm not mistaken. I can't remember when you guys looked at there's some histamine and antihistamines. You may have already looked at those, but there's the one on coagulation and on pernicious anemia. So take a look at that. And then Marissa, if you want to go ahead and give them the first 4 questions as a poll, and then you guys take those questions. When we get back, I will go over the answers to those questions, so you will have those. Does anybody have any questions before we break? Okay. So Marissa, you can go ahead and do the poll for the 4 questions, and then we'll go from there. And then I will see you guys at 1 o'clock, and we will start talking about heparin.